could you talk about how you're using artificial intelligence to maybe speed that up or integrate that information?
Well, that's true, and from the respect of having the data, we, first of all, if we want to go for genome, we need the time to sequence the genome, and even if we speed it up in our facility right now for a week, it's 7 days, and you normally start the treatment, the induction treatment for the AML before 7 days. So I think it will not be very helpful at this time of the time how to sequence the genome for the induction start of the respective treatment. But after the induction has been done, after 2 or 3 weeks, you will have the data available if you include a lot of artificial intelligence tools. And that means you need a specific software that also is doing a lot of its own, because you couldn't start with all these cases every day from the beginning. By learning tools like machine learning tools and self-organizing maps and others that I showed in my talk as well, we will get help from these artificial intelligence software tools to get this information done within, let's say, 1 to 2 weeks after we receive the samples, and that will hopefully influence our decision-making after the induction treatment.
So, Klaus, in your talk this morning, you focused on some of the practical aspects of what we do with some of these epigenetic mutations. Could you talk briefly, just sort of summarize?
One of the aspects we are interested in our work is to perceive AML as a dynamic disease, and one thing that I find very interesting is to study the evolution of leukemia. And one of our recent results was actually that when we treat an AML patient with induction chemo, we often see that they clear their leukemia clone, but on a molecular level, they do not clear all the leukemia-associated mutations. And we do see that what we call pre-leukemic clones, which look normal under a microscope, but molecularly they already have a subset of the leukemia-associated mutations. They still can be found in patients who are in a remission. And then when we look at the outcomes of these patients, we see they have a way higher relapse rate, probably unless you transplant them. And I think that prompted a very interesting discussion this morning, because this by itself is an interesting observation, but we don't really understand how these pre-leukemic clones, which are not the same as MRD, they are not leukemic cells, so how do these cause or associate with relapse of the frank leukemia clone? I think that is very poorly understood. And then the other question was, when you actually look deep enough with very sensitive methods, you will probably find persistence of such leukemia-associated mutations in the leukemic clone or in a pre-leukemic clone in almost each single patient. So then that, of course, brings up the question how can we include that in our clinical management decisions? Can we define a cutoff that helps us to identify patients who will ultimately relapse? And then do these patients need additional treatment, maybe in the form of maintenance therapy or allogeneic transplant? And on the other hand, if there are patients who have persistence of a pre-leukemic clone, maybe at a very low level, but they don't relapse, then of course, what is the mechanism for that? How is this clone controlled?
And so we've long known that there really isn't an effective maintenance therapy for AML, but we haven't really tried one based on either the genetic complexity of the individual patient's disease, and to be honest, our agents that we're using as maintenance are, as what I described, crowbars attempting to do needlepoint. They're very crude things. So moving forward, where we have targeted agents and we have this genetic information, this epigenetic information, can we individualize, personalize the medicine for each patient? And so this raises the issue of the trials might be very tiny. We're going to have to pool patients, work together internationally, I think, to generate these sorts of trials.
And it's the more general question of developing not only prognostic biomarkers, but predictive biomarkers that tell us how to stratify our patients to the most effective treatments. And we briefly touched the topic of the hypomethylating agents, which, as we discussed, do not only act by hypomethylating the genome, but also by cytotoxic effects, of course. But they are very widely used in the clinic, and I don't think we have good biomarkers that tell us which patients are going to respond to decitabine or azacitidine. And I think like intuitively, you would think that mutations in DNA methylation pathways should somehow be related to the efficacy of demethylating agents, but we don't really have robust biomarkers for that yet, and I think that's
it all made so much sense 20 years ago.
Yes, yes. Well, the more you know, the less you know.
Yes.
That's
All right, I think then that wraps up our discussion after our morning session, and I'm here at the International Workshop on Acute Leukemia.